Okay, so let's start this because we don't have that much time. I hope that you guys looked at other people's rapid updates online. I thought that they were very good. Some of them were really good. So what we're gonna do today, we're gonna talk about a couple of things, and then project components and some other stuff, and then we'll discuss the project. Okay. So one thing that I wanted to talk about is this is November. This is middle of November almost. So really you should aim to have your PAC members and really your first PAC meeting by the end of the year, which really means by December 15th, because after that it's university and everything closes and everybody goes on vacation. So it's not really working. The same thing with RB, you really should aim on submitting your RB as soon as you can. So, but certainly by the end of the year, and again, 15th, and that's, it's also a little tricky because of us, nobody's gonna look at it. So really you should aim by submitting it in the next 2 weeks, if you can. The other thing is that if you have your PAC members, I would suggest running it by them and sending it to them and having feedback. If you don't have your PAC members or they haven't given you feedback, then submit it, but still take their feedback. So when you actually get your RB back with your revisions, etc., you can always make those amendments, right? So it makes the procedures faster. Now, when I talk about having your RB submitted, that really means having your projects well in place, which I'm going to talk about, okay? Again, for the RB, you have to have sufficient description of the problem. It has to be specific versus vague, although some things can be vague, like methodology. Like for example, we're gonna, and I talked about it, qualitative analysis rather than specifying, how exactly and what exactly is going to be. Methodology, what sample size, why, benefits and risks, deliverables, additional documents. So what, one of the things that I've sent you back those, so I've sent you back those RBs that you have submitted. Of course, there was a draft RB. I wouldn't necessarily be too concerned with if you got basic, proficient, or advanced, etc., because it was a draft and it's not a mark that's going to be on your transcript. It's something that you take feedback and you improve moving on. Okay. One of the things that none of you did, even though I talked about it and possibly I was unclear, is you have to have all the attachments when you're submitting your RB, which means, if you're talking about interviews, what are your questions? If you're talking about surveys, what are your questions? If you're talking about consent forms, what is this consent form looks like? Okay. So you have to have all the documents there before you submit. Next week we're gonna do present, if any of you wants to talk to me about this RB, we can. Now the feedback is there. Some of them I put quite specific feedback on the thing, so you have to address it. The trouble is, and I perfectly understand that, I basically looked at what you sent me, but I know that some of you don't have the projects well developed, and therefore the RBs are not specific, which is normal. But again, it's kind of what you had there so that you know what to do for the next time. December 10th, I believe, we have presentations to first-year students. These are gonna, not only to first-year students, I just asked Jordan to send invitation. I invited the chair of the department, Rita. I've sent, we are inviting all the instructors. I've asked Jordan to send invitations to other people that are associated with RPs, with TRP, so there might be other people present there. And the other thing is that there's going to be we're gonna go to the pub afterwards, and therefore And so as such, there's probably gonna be more people that's gonna be present there, right? So it's gonna be a 7-minute presentation, 3 minutes questions. We're gonna be very exact on that because we don't have time. We have 14 presentations that we have to go through. And we have 3 hours for that, right? And you do want to get some feedback. What I am going to do, in this case, it's gonna be extremely important that you send me your presentations the day before, so I can upload them into one folder, and everything's gonna be going from one computer, okay? That just to make this more streamlined rather than everybody connecting their computer, etc. Okay, so just to make it faster. For those presentations, it's basically, remember, you're presenting it to the first year student, meaning you're presenting to the audience that does not know your project. So the main thing is, what is the need? Why are you doing it? Why is this important? Why, should you even do this project? Why should I care that you're doing it, kind of thing? So what you are doing, why you are doing it, how you are doing it, what is the progress, what are the next steps that you are doing? Okay, but the main thing is that intro, you have to provide the context, and the same is true for some of your REBs. The same is true for your rapid update presentations. It's background and context, even though those rapid updates were for slightly different audience because they were for us, and we've already heard each other projects. Hard to remember. It's just saying, everybody's project, and plus they kind of change a little too, so you really have to provide that context. Now, this year the classes are in person. This class is once a month, so you really should, and I'm talking, so really everybody should be here in person. I understand that things come up, but like I said, this class is once a month. So unless something came up that just came up and I really, really need to be online or cannot attend, that is understandable. Stuff happens, okay? But you really have to, it's commitment to your project and commitment to everybody else in class that is here and provides feedback, or could use feedback, which you can provide online, but it's not the same interactions. It is extremely particularly important for the December presentations because we're gonna have some guests here, and you get different interactions when you're here. And of course, we have a social afterwards. Okay, the Get Talking event is on November 26th. We're gonna be talking about indigenous health. I know all of
Share the screen and put your slides up. I don't think they're seeing it on.
Oh, I am sharing it.
It's just now moving to the next slide.
Huh. No, it's not moving. Now it's moving. Oh, so if I use that, if I use this, it's moving. If I use that, it's not moving. Okay.
It's still
not moving.
okay.
What?
There. But now we see your notes as well. It's like
Okay, why is this doing this? I don't have any notes. Okay, let me see. Hide presenter view. Right, now you can see it. Now, can people see it online?
You still see presenter.
What?
Oh, now it's just.
It's just.
Here we go.
Okay. Get Talking event is on November 26th, indigenous health. I know that most of you already have projects, but we're gonna have 3 people that actually their background is indigenous, and they are working in different fields. So one is from Attorney General's office. She's very, very experienced and work not only in terms of law and in terms of legislation, but she actually worked with a lot of communities. So, Little Native Hockey League and She is the president of the Anishinaabe Health Center and all these other things, right? Another person is from University of Toronto and she works mental health, I think, and indigenous people. And another person is a nurse practitioner who is teaching at York University. So this is a very good thing. So I think, you know, you never know when you're gonna end up, and I think it's a good place for you to come. One thing that I forgot to mention for the presentations for first years, and I'm gonna send a reminder email. Kate and Janie are gonna be here an hour before, and they would like to interview you for, you know, certain things for projects. Instead of recording your presentations, each project will be kind of interview. You can say a few words, and they're gonna post it online and use it for, you know, promotional purposes on our LinkedIn site, etc. I would suggest that at least one person from each group is here. If not all the people can make it, then maybe you can designate a person that could come a little earlier and do that. That would be great for people online. So Federico, Dominique, and Christina, I know you guys cannot be here because you're out of the province. So we're gonna arrange for some kind of online questionnaire. Okay, so I already said that R&B and PAC before the end of the year. So, you know, 2025 is around the corner. Like, we need to get on these things because that's gonna take a while and we're gonna get there. I wanted to take a couple of minutes to talk about creative problem solving. What is creative problem solving? It's basically generating of innovative solutions, but thinking outside traditional research and healthcare boundaries. This is what we want you to do with your capstone projects. This is why you are in this program. This is why a lot of organizations want to partner with us, because they want that, you know, the fact that you don't have expertise in the area that you are working in, it's actually an advantage because you can come in with a fresh mind and you can kind of look at it from a different perspective versus when you are in something all the time. And a lot of you know, when you actually write a paper and you've been writing this paper for the last 2 weeks, you don't see the mistakes anymore. Okay, because it's just ingrained in your mind and you can't see it. So it's the same thing kind of when you are in the institutions like this, when you are working on something, you don't see the forest for the trees. I think that's how it goes, maybe not. I usually kind of mix those up generally, but that's basically it. Key strategies, interdisciplinary collaborations, which is what you're doing, iterative prototyping and testing, patient-centered design. So these are the three main components of your capstone projects. When you are developing your projects, when you are developing your protocols, these are the three main things you have to consider. As you know, we always say, go and talk to people, which is like the first part of it. This is from the purposes of the RB and what you need to do in order to have like a good RB or a good study design. So these are the 10 kind of points that I've made. Now, not all of them are actually relevant to all of your projects because it depends where you start. It depends what you are actually doing. And it depends what your deliverables are. But technically, what you have to think about, understanding the problem and the context. So some of your RBs, it's interesting because some of your RBs, you know, I know a lot of your projects and I have meetings with you. And I know that you have way more information that you've put in the background of your RB, okay? And your background in your RB does not actually describe why this is a need and why this is a project. I think one of the groups that I think had the best introduction to, or two groups that had the best introduction to their RABs. It's Maris and Fernand, but they've already submitted, so that's expected. They've worked on it really, really hard. But the other ones are the Dementors. Your introduction, and some of you might actually want to get there, was very, very good. It went from the broad perspective of why we are doing it to what we are actually doing it with references and everything else, right? So this is really important because the RB and whoever you're presenting your project to, they really have to understand what it is that you're trying to do. Sometimes, you know, Gilbert and I would go to meetings like, yeah, but we don't actually understand the project, which, you know, it may be on us, but it's also on you to communicate it properly, right? Objective setting and goals. So in IDPs, and you've had those last year, you know, we are always talking about SMART goals. So they have to be specific, they have to be measurable, they have to be achievable, they have to be relevant, and they have to be timely, right? So, you know, scope is very important. Some kind of measure and evaluation is also important. Evidence-based innovation. So of course, you know, what is the evidence? Study design and methodology. Ethical consideration, stakeholder engagement, intervention development, implementation, evaluation, and dissemination. So this intervention development, you know, some of you might not be doing it, some of you might be doing it, some of you might not be doing evaluation and continuous improvement, but some of those things, like, so for example, if you develop an intervention, but you don't have time to implement it, you write, you know, how you would implement it, etc. But you still have to have a plan of how would it be implemented, how would you evaluate it, how would you measure, how would you disseminate, right? So you still have to have a plan that talks about it, even though you didn't do it. So your scope is one thing. So this is what you do for your project. This is the main project, or these are the things outside the scope. You can address that. Because some of you already submitted your RB, I just wanted to mention a couple of things. Mainly, you know, when you talk about data collection and analysis, you have to think about three things: participants recruitment, data collection, data analysis, okay? In terms of participant recruitment, there are different strategies. There are, you know, social media, there are like passive strategies and active strategies. Active strategies when you actually have people's contact information, so they come to you, you know who they are, and then you have to de-identify. Passive ones, you know, when they come to you, you might or might not have the contact information, but you are not actively recruiting through emails or phone numbers or etc., but you're just posting posters somewhere, okay? When you write your RAB, you might include some of those or all of those, or, you know, few of those. You want to be as general as possible, even though your best strategy might be through email recruitment. You might want to include posters, because if you don't and it doesn't work, then you have to write an amendment, right? For the recruitment materials, usually you need a poster, or an email. You need what's the title of the project, the name of the PI, so the names could be yours. On your RAB and on your recruitment materials, you should always include your capstone supervisors, because it's not just the students, like we are semi-responsible, well, we are responsible for you. Statement indicating that this is a research study, purpose of it, eligibility criteria, commitment that's required. So people like to know if it's half an hour, 2 hours, etc. Okay. Location, is it in person? Is it online? When is it in person, where it actually is? And potential direct or societal benefits. Now, for your RAB, okay, the risk usually in 95% of the cases for your RABs, there is no direct benefits. Okay, because you are not actually helping people that you're talking with, right? So you're not actually providing a benefit to them, but there could be long-term benefits to that person, or they could be societal benefits later on, right? So if you improve the process, then yes, but if they helped you to improve the process, you did not actually help them, right? So for most RABs, there will be no direct benefits, but there are cases where there might be some. Okay. One thing that you have to think about is undue influence, withdrawal, compensation, bias limitation. So withdrawal, what we usually say is that, you know, you can withdraw at any times. If the person came to an interview and you told them when they do an interview, you give them a gift card, you have to give them a gift card, even if they stop interview mid-time or a survey or whatever. It's not really a compensation, it's more token of appreciation, or you can talk about compensation. For your RABs, it's usually between $10 to $25, because it shouldn't be high. You don't want to coerce people into participating in your study, right? So it's kind of just to give them money as appreciation. I mean, undue influence, it's meaning if you are recruiting, if a doctor is recruiting their patients, and the patient might be afraid that it's going to affect their their treatment, which is one of the comments, that, you know, you have to make sure that the people, they know it's voluntary and it has absolutely no effect on their treatment or other things that's going on, right? And what are the bias and limitations of the study and also of participant recruitment? So one thing, when you think about it, is think, who do you want to recruit? How do you want to do the recruitment? Where are you doing recruitment? How many people do you need? Okay, and depends on what you're doing, you can actually calculate the power statistics. So how many people do you need to get a statistically relevant or statistically significant answer? How do you gonna screen them? Is there a pre-screening strategy? What's the screening strategy? Exclusion and inclusion criteria. So the way you do it's like with everything else we are doing in TRP. So you have a strategy, you execute that strategy, you look at the response rate, you adjust, and you make a new strategy, right? So a lot of the times, you know, participant recruitment is tricky, and we found many times that sometimes it goes amazingly well, and you just recruit people in a week and you are done, okay? Lots of times, for some reason, it doesn't work as well, and people have students have very hard time recruiting participants. Now, sometimes it's because of the patient size, so whatever it is that you are studying, because the sample size overall is so small, like if it's very disease specific, and that disease is not that frequent in the population, then of course you're gonna have harder time recruiting patients. So when you do inclusion exclusion criteria, you have to think about these things, and you have to think, how many people can you actually recruit? What is the population size? Do you make a wider spread? So for example, do you recruit people just from GTA, or do you recruit people from Ontario? Do you recruit people from Canada? Do you recruit people internationally? Of course, you're getting different effects, because if you're only talking to 20 people, they're gonna be from all over the world with different healthcare systems. It's tricky, because how are you gonna analyze the data? So again, it's gonna depend as you know, what is your objective? What it is that you're gonna find out? And in your case, is it reasonable to do a very focused study, or to do a wider study? It depends on your research, right? You had method scores last year, so you know all of this, but this is just a reminder. You have quantitative, qualitative, mixed methods. Now, one of the reasons I'm talking about it at this point is when you guys submit, even though your RB, you know, is extensive and it has all the protocols in it, etc., when you submit it, you can work on other components of your project. So for example, you can then think, okay, how are we gonna analyze our study? Okay, and this could be a quantitative method or qualitative method, depending on what you are doing. If it's qualitative or quantitative, what kind of methods are we gonna be using, right? So you actually, you know, even for participants recruitment, are we gonna recruit through email strategies, right? So when you submit your RB, you can then actually reach out to people and say, okay, you know, we submitted this RB, would you be willing to send it out to your people once we have this? So you have to have all of these in place after you submit your RB, right? Data collection, it's survey, interview, focus groups. All of these have different places. You get different information from each one of them. Survey is good if you know what you are looking for. So for example, if you know what questions you want to ask and it's a simple answer, survey is good. Survey can have open-ended questions as well. So it can be mixed methods format. Interview, if you want to get people experiences and really people's opinions on the subjects, are really good. Focus groups are better for discussions, okay?
For those methods, how would you capture if you invited people in to review a document? So those kind of presuppose that there's a verbal exchange. But if we think, for example, how the minister engaged with us, it was they gave us a document and we were able to submit written things to prepare ourselves and
But it's-
also have the reflection before, an in-person interview, but there were both.
But they didn't really interview you. It was a discussion.
Yeah.
It was a focus group.
So there was focus group, yes, and there was also a written.
No, so for the focus group, so I guess that the meeting that we had with the minister, I would classify it as a focus group. For the focus group, there are different types of focus groups, so you can send your participants information beforehand, and a lot of people do, depending on the objective of the research, right? So you can send them information, they can read it, and they can come prepared to discuss it. So you can do that.
Is it acceptable to invite written submissions and collate feedback that comes from? written
Sure, if
insights?
it's in your RB.
All right, so we have to take it back. Okay.
Okay. Right, so for all of these, obviously survey, you can do quantitative analysis, which is statistics, which is, other like, some of the clinical studies are quantitative. And of course, qualitative methods, there's many of them, okay? A lot of our students use NVivo just because it's free for University of Toronto students, and the library actually has courses as to how to use it, okay? But there are many others that might be more specific for certain things, so you should look them up. Okay, questions about all of this? I don't see it. Oh, in the chat.
Yeah.
Okay, what is the question? Read it. You guys can talk, actually.
Are we allowed to choose a mix of data collection? Like, we may want to start with surveys, what
Sure, of
questions-
course. Of course, you can choose. So it depends on what your study protocol is and what your objectives are. One thing that you have to be aware of is scope. Okay, if you do your study like in 2 or 3 stages, imagine that for every stage, you need some kind of recruitment strategy, and then you need to collect the data, and then you need to analyze the data before you go to the next stage. So the scope is a consideration there, but of course, if you have different stages for different things, then yes.
I was wondering about sample sizes. How we done it for here and sampling strategies, but like how do we reconcile feasibility with what's
Can I do an add-on to that question? Because I remember watching, I forgot what the group was called, but it was Abita's capstone defense, and I remember the LMP representative had a major issue with their sample size. It was really small. So
Anybody knows the answer to this question? Huh?
there's a point.
So, well, the formula, but there's also in quantitative, there is a formula, how do you get power statistics, right? And sometimes even in qualitative studies is different, but in quantitative, you can do, what's the size of the population and what do you need to get statistical significance. In qualitative studies, most research suggests that between 12 to 15 gives you saturation. So in qualitative study, the idea is saturation. Okay, so basically you interview, so once you see the same things coming up, like repeating, then you achieve saturation. Now, the trick with that is, if you interview 10 people and the 11th person, or at least, so when no new things come up, right? And the 11th person says nothing new, then you can't really stop interviewing because the 12th person might, right? So, so there is some kind of a leeway there, but the actual answer is saturation. And so you should read up about saturation and what it is and what do you need to achieve saturation, right? That's what it is. So it's probably somewhere, I would say that it's generally between 12 and 25, depending on what you do. When you interview different stakeholders, when you guys say we're gonna interview different stakeholders,
Mhm.
when you interview, when you interview physicians, specialists, patients, etc., it's exactly, it might be different because remember, they all have different perspectives, right? So you're kind of asking them slightly different questions, in which case you now have to achieve saturation with each group.
How do we, assess the saturation if there's focus groups and maybe in each focus group, you have 5 people, but you only have 3 events?
Right, so with focus groups, you don't really necessarily achieve saturation, but it is understandable that they are not necessarily generalizable either, right? It's about in focus group, it's more like how many people participated and how many people of different like how many physicians, how many nurses, how many patients type of thing participated, okay, in a way to get that diverse perspective.
So if we get, say, 15 people within a specific demographic of experience, whether that be like doctors, and there might be another cohort of 15 that are ESWs or another 15 that are patients, then that might be considered like, maybe it's 3 focus groups of 5, but that might mean.
Yeah.
Just with regards to focus groups, I think also usually like with focus groups, you tend to use them for more of a specific audience rather than to generalize to the public. So they wouldn't really like need saturation because you're trying to tailor it to that audience.
Right, so you use focus groups for specific things, so that's why, for example, you use focus groups for generating ideas, not necessarily for collecting ideas, right? You use focus groups for co-design, for example, so you have an idea, how would you do it to get feedback, right? So it's different than actually collecting data about people's experiences, which is why I'm saying that what method you choose, so survey, focus groups, interviews, depends on the objectives of your study.
So for quantitative studies, you said that the sample sizes that is from the stuff that you use to calculate based on the patient population, right?
Well,
So-
depends what it is that you're studying.
Okay, so we're thinking, so let's say you're talking about patients with diabetes, but you actually have your studies geared towards the physicians that are treating diabetes. but
So
that's-
it would have to be geared towards the physicians, not the patients.
So then the population in question would be the physician population that,
Anybody else? Okay, so one thing that I want to talk about, so I don't know, did you guys see the updates? Come on, I need an honest truth. I sent you a thing on Teams that I uploaded those
Oh,
rapid
that's what you-
updates on the thing. Did you see them? You tell me the truth because, so, okay, what I am going to do, I would like to,
Watch them on the train. Then you're very nauseous. Yeah. They look very cool.
okay, I'm gonna show you two. I'm gonna show you two of them. Then we're gonna take a break. After we come back, I'm gonna ask each group to tell me, 3 things that they've done from the last update and 1 challenge that they're facing. Okay. Just to remind everybody what your study is about. Let me see. Which one? Oh. So I want to show Christina's, and Christina, of course, have been working on this project for a while, so it's slightly different. I'm not sure. Let me see if I can share it.
Yeah.
Oh, I thought it was about.
The TransCore, the Translational Success in Cornea Regenerative Medicine Project. Here is a normal, like a transparent window and allows clear vision. When diseased, it becomes a pacified, leading to reversible blindness. The only currently available treatment is corneal transplantation.
Because then when I make it full screen, I don't have us.
However-
Okay. How do you share sound again? Stupid
I need
thing.
to like reshare your screen and then share sound as well. So you have to stop sharing and then.
Stop sharing. Share.
What do you mean? Look, because you hit share sound on the right side panel.
Oh,
Oh, you have to click the X so you can.
Yeah,
then-
yeah, you just close the square box, yeah.
This is TransCore, the Translational Success in Cornea Regenerative Medicine Project.
Here is a
Small
normal
cornea.
okay.
It is
Sorry,
like a
guys.
transparent
One more time.
window and allows clear vision.
Why don't you go to sound?
When
type filter?
No, yeah, I know. That's what I need to do actually.
Reversible blindness.
Edita, do you think it's easier if I share it from my computer? Is everybody gonna?
Hold on, give me 1 sec. I'm just gonna figure this out in a sec.
However, there is currently.
I have to stop sharing.
No, I'll use the listen here.
Share. I know, but why doesn't it?
On regenerative medicine alternatives such as cell, tissue engineering, gene, and drug-based therapy. However, despite decades of
Hold on.
research, these have successfully crossed the valley of death from bench to bedside.
Why is it still?
Practice today, corneal transplantation remains the gold standard treatment for corneal blindness.
Okay. Okay, let me just do this. I need to. Do this. Yes. That's what I didn't do. What?
Yeah, that's true.
The problem is that cornea researchers struggle to navigate the translational process. Our solution is to develop a translational potential assessment and improvement tool to help them. Our ambition is to make safe and effective corneal regenerative alternatives available
Okay,
to
Christina, can
patients
you
in
share
need
it? I'm just gonna
faster.
stop it. This is ridiculous.
This tool will
How
directly
Click
corneal
the up arrow,
researchers,
the very
but
bottom
also
of the toolbar.
indirect
I did.
corneal
I clicked the
blindness,
stupid thing.
their eyes.
Okay.
So will be of relevance to funding
1 second, I'm getting there.
Okay, let me
or
just
cell
shut it off.
early in the development process. Our objectives are to determine the current state of translation of cornea regenerative therapies, with barriers and facilitators in this process.
Okay,
Can I go?
yeah,
Everybody sees the screen?
hold on. Yes.
Yes, okay, go. Let me know if you hear the sound properly.
Well, now we do.
This is TransCore, the Translational Success in Cornea Regenerative Medicine Project. Here is a normal cornea. It is like a transparent window and allows clear vision. When diseased, it becomes opacified, leading to reversible blindness. The only currently available treatment is corneal transplantation, which restores clarity and vision. However, there is currently only one donor cornea available for every 70 patients who need it. To address this limited supply, researchers have been working on regenerative medicine alternatives such as cell, tissue engineering, gene, and drug-based therapies. However, despite decades of research, few of these have successfully crossed the valley of death from bench to bedside. And in practice today, corneal transplantation remains the gold standard treatment for corneal blindness. The problem is that cornea researchers struggle to navigate the translational process. Our solution is to develop a translational potential assessment and improvement tool to help them. Our ambition is to make safe and effective corneal regenerative alternatives available to patients in need faster. This tool will directly help cornea researchers, but also indirectly patients living with corneal blindness and their eye care providers. It also will be of relevance to funding entities and industry who must make resource allocation decisions early in the development process. Our objectives are to determine the current state of translation of cornea regenerative therapies, including barriers and facilitators in this process, develop a prototype of a translational potential assessment tool for these therapies, and obtain the perspectives of cornea researchers on the determinants of translation and our prototype. We will proceed first with a literature-based analysis of the state of translation in this field. This data will be used to develop the prototype of the translational assessment tool. With the prototype in hand, we will approach cornea researchers for individual interviews to complement our literature-based analysis and obtain their feedback on the prototype. Our team is composed of myself and 4 research associates, Marianne Gingras, Dr. Alison Bernstein, Lorena Mija, and Miriam Belesh, and PAC members Drs. Mark Lesk and Kelly McShane, as well as Joseph Fehrenbach as TRP advisor. Thank you for listening, and get in touch if you want to learn more.
What did you think? Questions?
So you said in the beginning that it's reversible blindness. So what I didn't understand is if it's reversible, why do we want to be part of that? Like what aspect of reversible?
Did you hear, Christina?
So the question is whether this is reversible blindness and why do we want to, I'm not sure I understood the second part.
So if it is is it reversible? And then if it is reversible, why do we need a new cornea then?
Okay, so it is reversible through corneal transplantation. That's the only way you can reverse it. There are other forms of irreversible blindness, and that is blindness that comes from retina disease or optic nerve disease, where there is absolutely no treatment you can do to reverse the blindness. So it is reversible, but through treatment. Basically, we can do something about it, so we have to do something about it. There are other forms where we can, so unfortunately, there are not many avenues we can take to even come up with regenerative approaches.
Anybody else?
So we were tasked with the 3 things that they've done and 1 challenge. To me, it wasn't very clear what you've done so far. Like, have you started the literature review that you mentioned? No?
No, so basically this is the protocol of what we're planning on doing.
Okay. Thank you.
Okay, so the reason, yes.
I was wondering about, because you said that you want to create a tool that would, I guess, support, will have like, you know, it will help ophthalmologists, I'm guessing, with translating potential, therapies, right? So my question is like, why not just research, you know, the most important or the most promising therapies and just put them out there? Like, why the tool?
I'm not certain I understand. What do you mean research the most promising therapies? What do you mean by that?
I think what she's asking, what do you mean by tool? What tool do you need?
So the tool we were proposing is a tool that would help the researchers who are developing these therapies navigate the translational pathway. So basically, it's all fundamental researchers who are developing all of these promising therapies that work well in animal models, but they never get to the patients. And a lot of the issues come from the fact that they don't know or encounter a lot of obstacles in moving their therapies to the next following step. So you get to the small animals and you do the large animals, then you have to get to the first phase clinical trial, then the second phase clinical trial. And a lot of these steps have a lot of different obstacles and teams get entangled in a lot of that. And it's very tough to navigate. And this is why things aren't getting forward. So the goal of the tool would be to actually help them navigate that. And we don't know yet what exactly makes it so some therapies succeed and others do not. And the goal of the first literature review is specifically that, to try to find out which ones succeed, which ones don't, and try to compare what makes them work, what makes them not work. And then from there derive ideas of how we can build this tool for the researchers so that they can later use it and navigate this translational pathway easier.
Okay, so we're gonna, sorry.
Oh, okay.
So we're gonna move on for now, but the other one that the reason I wanted you to see is because, you know, some examples of how clear your presentation should be, even though it's for the class and even though we heard Christina's talk before, it's still great to have that kind of presentation. And these kind of presentations can really be used to introduce your project to your committee members. Right? Because you do it before the committee meeting, you do 3 minutes, it's clear, you are not stressed out because, you know, it's pre-recorded, although you're also a little stressed out when you record it. But it's easier for you because, you know, it's the first time, etc. The other one that I wanted to show is Cheyenne. You want to share your screen?
Yeah.
Just because it's, well, for those of you that's seen it, you know what I'm talking about.
What are we called? It was a hustle, I won't lie. We did it. Okay, yeah, you're right.
Okay, ask your question, Mikhail.
Oh, I'm
Sorry.
sorry in the chat.
Oh, okay. So. So yeah, so you can include additional questions on the chat and comments. Like, remember, this is the reason I do sometimes those and you know, you can provide feedback, but the reason we do, or I want feedback, we do those pre-recorded ones is so we have more time to actually discuss our projects and do other things. And I also think, like I said, it's a good tool to have.
Sorry about that.
Allegedly.
Nice start. Is that okay?
Yeah.
Hey there, it's Cheyenne. Looks like I'm in cartoon form for this update. I'm going to give you a tour of team headquarters, Prepping Inc. We've been busy at work with our project.
I would leave.
Oh, what's that? You don't know what our project is about? Okay, I'm going to pretend I'm not offended. I'll give you a quick recap. So we are looking at pre-exposure prophylaxis, or PrEP, which is an HIV preventative medication. When used properly, it can be up to 99% effective in blocking HIV infection. The problem is that PrEP is being underused by people who are eligible to use it. Now, like all health systems, this gap is a result of multiple problems. But a contextual inquiry with pharmacists, community health workers, and community members have suggested to look at the Trillium Drug Program, or TDP. TDP is a provincial health coverage program designed to offer financial support to those who require assistance in paying for medications. PrEP is covered by TDP, but the application is difficult to navigate, an informational and time barrier which prevents potential users from gaining coverage and in turn preventing them from using PrEP. By working alongside relevant stakeholders, we hope to develop a tool that will facilitate the application process in attaining Trillium Drug Program coverage. Now with that out of the way, let's go inside. Oh look, it's Laura, and she's got some paperwork. Whoa, look, those are our PAC members. Dr. Daniel Grace is an associate professor in the Dalai Lama School of Public Health. He has SGS supervisory status, which is super great. He specializes in social and structural determinants of health, HIV prevention, intersectionality, and qualitative research methods, which perfectly melds with what we're trying to do in our project. Oh, and look, this is Ruri Piresh. He's a gay men's education coordinator at the AIDS Committee of Toronto, and he has decades of experience in 2S LGBTQ sexual health promotion across Ontario. Looks like Laura is in the process of onboarding them right now, which is great, but I wonder where our third PAC member is. Satar left a note that she's out here. I wonder what she's doing. Oh, there she is. Huh. Looks like she's trying to hunt for something. I wonder what. Maybe that clipboard has some answers. Ah, yes. Our final PAC member. We're hoping to get someone affiliated with the Trillium Drug Program to give us some guidance through the policy. I'm gonna leave her alone. I don't want to scare away a potential PAC member. Let's go check on Zoe. I'm pretty sure she's in the design studio. Oh, there she is, and she's with our mascot, Wally. It looks like they're hard at work in finalizing our team's brand. That includes our color palette, our logo, and also making a cool introductory video for our project. Sounds like a lot of work. I'm gonna check out what I have to do on my to-do list. I'm pooped. All right, let's see what we have going on here. This is a hefty to-do list. First, I gotta develop Microsoft Azure skills. Of course, we gotta wait for that ethics response. We have to continue investigating the problem space as well to ensure that we're properly addressing community needs. Looks like we have our work cut out for ourselves. I'm gonna kick you out, but until next time, see ya.
Okay, so you saw that one too. So there are different ones, right? One of them is quite serious and one of them is cartoonish and we are all laughing. Now, it also goes to the audience, right? So for us, for a particular audience, for presentations to first years, it's actually it's a very good, funny kind of cartoonish presentation. For presentation to PAC members, it might be a little bit adjusted in terms, probably not even the presentation so much as maybe the wording, but that's the idea, right? So you can be creative with these. They are helpful to you. I believe at least that it's not a waste of time, again, because they are reusable and they're a good way to show what you are doing, okay? Questions for the group?
What is Microsoft Azure?
It's basically like, from what we understand, it's like a coding sort of software. So when you think we were to go with the routing and all that tool, it's like a secure way to, create something and to store any sort of data. Okay, yeah.
Why didn't you?
Because the easier platforms were in the other biotics. So just Microsoft is that's true.
Gilbert, do you have any questions for it? Seems extremely clear. Okay, so let's take 5-10, let's take 10 minutes break. And then we come back and we discuss all the other presentations. We can, think about showing some of them if you want to.
Be honest, how would you like pictures?
Literally, I started, let's just say it took me one day to make everything, and then after days to put all the top and the sun.
What? I say
It was a speed run, thank you.
That's not to say that the other presentations were not good. They were. I just wanted that contrast. Oh. Chocolate? No. I still have some, yeah.
Oh, yeah.
Yeah,
It's not very nice.
I
I get that. I know. It's an interior. It's like, you know, like, you said, but it's way from the baby. Yes. Exactly.
That's exactly what she said.
3 months.
Exactly the context of the
I'm sorry to tell people now. Guys, disclaimer, that was a joke. I said something. I just thought I was announcing.
So weird, but
I don't think I would announce it to the capstone. Oh, we were not. Oh my God.
Okay, okay, everybody, after all this sugar rush, let's come back. Okay, so what we're gonna do, each group is gonna say, you know, the title of your project or the objective of your project or what it is that you are doing. Three things that you have done in the before the last time we had this meeting, and one challenge that you are thinking, okay? Start, somebody.
We can go first.
I'll say two things, you say the next two things.
I can say the challenge.
Okay, so, two things we've done so far, three things we've done so far. We sat down and we started consolidating all of our information. So we had a lot of, stakeholder,
What?
like, we did a lot of background research, we did a lot of contextual inquiry, basically for the past 3 months. And we ended up with a lot of data that we put down all into a chart on a whiteboard. And then from there, several times actually on a whiteboard. And from there, we have now identified a proper research question, proper population, and proper way forward.
Good.
Based on feedback from you guys.
Yeah.
We spoke with a couple of people, alumni, and we actually we received a common response from just about, I think, everybody. And we've done a lot of work, we've spoken with a lot of people, we just have to pick a direction. So that's what we did last week. We've sort of, picked a general direction.
Okay,
guess
no,
the-
it's way more specific than general.
I mean, like, the point is, the challenge is that it needs to be specified further.
Yeah.
That would be
So we have our population, it's not patients actually, it's the
yes.
referring physicians, that's our population. And our question is, and we also have a kind of idea on how we want to get to them. Our question is, why are they referring the patients to the two pot specialists in Ontario
Instead of doing the test
instead of
themselves.
doing yeah.
Questions? Anybody, comments? Who saw revamp
You guys
presentation?
helped us get there.
Who saw it?
Ah.
No, from the
I know,
updates, the online
so-
voice recorded presentation. Who saw it?
Whose voice was?
Okay.
Nobody.
Well, to be fair, we did ours.
You guys all failed capstone course. No, just kidding, okay? But you have to look at those because the idea is that it gives you an opportunity to see how other people did things, okay?
Yeah, we'd love feedback.
There's a comment in the chat.
The comment chat.
Is there a comment in the chat?
Okay, how about you share your presentation? Go.
Okay. Okay.
I think we're gonna have to share these presentations.
I did. Oh, do you want to do?
Right,
Because
okay.
it's harder on an iPad. So go to our Teams channel.
Whose channel?
Revamp. Files. Scroll.
This one?
Rapid updates. Okay, yeah, and now share screen. Let's share. Oh, no.
Did it work?
No, you're not sharing sound.
I have shared.
No, you're not.
Syndrome. Standing or being upright.
You can restart it. Oh, I have my podcaster voice on.
It's really common.
Hi, I'm Mikhail from Team Revamp. Project on POTS. That's postural orthostatic tachycardia syndrome. Standing or being upright often triggers POTS symptoms, making it feel like you're literally defying gravity. POTS patients can present with a myriad of symptoms, but most commonly, these symptoms include lightheadedness, tachycardia,
I
presyncope,
shut off mine, it's
headaches,
not me.
and
Like
difficulty
I just open
concentrating.
it again, that
Patients
doesn't
with
make any
POTS have
difference.
reported to suffer from a degree of functional impairment, similar to that seen in conditions such as chronic obstructive pulmonary disease and even congestive
Well-
heart failure. Still, these patients are frequently misdiagnosed. Our capstone is aimed at improving the diagnostic journey for patients with postural orthostatic tachycardia syndrome.
I'm not, it's the audio is
Making sure
loud.
they get the care
No,
that they
but that,
need
but
in
it
a
was
timely
like this when
fashion
I was listening
so they
to
can
it.
live
Your
their
voice
best
is like,
possible lives. Okay,
I was speaking really loud.
basically, we've been struggling with direction, so we decided to consult some TRP alumni. First, we spoke to an alumni from about 2 years ago who was an internationally trained physician. He assured us that we were on the right track and all of our stakeholder engagement was very much good and what we should have been doing. We showed him our swim lane diagram, pictured here, and he told us to consider either a patient journey map, an ecosystem map, or a system blueprint. Based on our conversation, he suggested that our impact could be a reduction in diagnostic delay by highlighting the gap areas for future intervention and planning. We were still a bit hesitant, however, because we don't want our entire project to just be a map, and we want to aim for more of a tangible impact. We also chatted with a TRP alumni who has a nursing background, and they also appreciated how much work we put into understanding POTS and how it affects patients and our stakeholders and physicians, and just trying to approach the problem from every angle. Suggestions from them included considering a qualitative study and specifying our patient population. Suggestions from them included considering a qualitative study and specifying our patient population to focus on a population that's not only impactful but also accessible to us, and also starting with a simple plan, because the more work we do, the more complicated it's going to get along the course of our study. Now, our goal has shifted a little. We want to work with one of the specialists in Toronto and look at her waitlist, or the patients she's seeing right now, and talk to their physicians. We want to see how many references it took to get to her, and why the physicians are referring the patients instead of following the guidelines. This way, we can systematically look at the current state and identify barriers that are preventing doctors from diagnosing POTS.
okay, questions? Any questions? Any comments? What do you think? Gonna try this again. Nobody. Okay, I'm gonna try this again.
Hi everyone, today I am presenting on behalf of Team Cancer Survivorship Navigators, which is myself, Aflin, and Alia. So a quick overview on our project. We are working with Princess Margaret in parallel with another team to address the burden of the high volume of patients in follow-up care.
Do you guys hear it
Princess
online?
Margaret has proposed a risk-stratified approach to this problem area. Our team has the opportunity to focus on Tier 4 patients, patients who are deemed low risk and able to transition back to family care. Our primary goals are to determine what resources primary care providers need to take on follow-up care for these patients. The parallel team will assist in this process by gathering information from specialized cancer care teams at Princess Margaret. We have just finished phase 1, which was our preparation phase. As mentioned last class, this phase consisted of an informal literature search to discover common themes that have already been reported. We used this information to create a conversation guide for contextual inquiry, where we had the opportunity to talk to 3 family physicians. We were able to use the themes brought up during these conversations to create a bank of survey questions. In the last week, we have condensed our survey and are preparing for dissemination. Based on feedback from PCPs, we plan on posting the survey on physician Facebook groups and using snowball sampling. In addition to the survey, we have also been working on polishing our QI application to be submitted as an addition to the Princess Margaret application. Some additional deliverables we have accomplished were submitting an abstract to the ACTS conference and brainstorming PAC members. This slide shows an example of one of our survey questions. We originally had brainstormed over 30 potential survey questions. After speaking to the Princess Margaret team and physicians, we concluded that a very short survey was necessary in order to accommodate physicians' busy schedule. Ideally, the survey would be between 5 to 10 questions. It was important for us to maximize the information we can get from these questions. We decided that all questions would be multiple choice for efficiency. However, we did get creative with the way we asked them. So for example, in this question, while it counts as one multiple choice question, we are going to be able to get information in 4 different areas. Once data from the surveys is received, we plan on using semi-structured interviews in our next phase to expand in areas that were important according to the data. Additionally, we will use these structured interviews to gather information that was not addressed with the survey. Our next steps are to finish finalizing our survey questions with the help of the Princess Margaret team. Once we finalize the questions we will ask, we will formate the survey to REDCap. We aim to have this completed by the end of the month and begin disseminating the survey.
Okay, what is the challenge that you guys had recently? What's the progress? What's the challenge?
Oh,
Yes.
our recent challenge was we weren't able to specifically state what our need, problem, and scope were. And so our group spent a lot of time this weekend really trying to understand who we were trying to help and why we were trying to help them, and who would be the main beneficiary of the work we were doing. Originally, we had thought that the work we were doing would be helping primary care providers. We realized that the primary care providers would actually be our audience, and the oncologists would be the ones that we'd be helping most, because we would be helping them change the way that they create their discharge summaries and provide them to PCPs. And so because the oncologists are the ones that are going to be doing the bulk of the work and the bulk of the change, they would be our main beneficiary. And so now that we've kind of rethought how and who we're going to be helping, it really scopes what types of questions we should be asking and what types of data we need to be collecting to actually do the like dissemination of our project.
Questions, comments?
So the survey would be targeted to the oncologist.
No, so our survey would be targeted to the PCPs because we want to understand what communication looks like for them right now. So we also did reframe our question. And so we no longer want to focus on the broader resources. We're going to focus in on communication because we identified that as a big barrier for PCPs and oncologists. And so we're gonna survey PCPs and ask them about the communication, what it looks like, what they would like it to look like. And then there's a parallel team at Princess Margaret that will be asking oncologists about that same process. And then we can work together to kind of see where are the barriers together. And by taking like a dual approach, we're getting perspectives from both sides. We don't really want to include patients in this just yet, but we're thinking of including a few patients down the line when we start to think about what those care pathways would look like.
Questions, comments, guys, if you're on your computer writing messages, you shouldn't be doing that.
If it's self-reported, will they rate themselves negatively, the PCPs, because there was a scale, right? Will people actually say, oh, I don't have skills in this?
Well, if they don't have the skills, we're hoping that they say that. Because that indicates to us that there needs to be some sort of change or support put into those areas. But then our group has also decided to do those structured interviews where we see areas where there's increased need and where we see areas of discrepancies, just so that we can get a more personal understanding of the problem and more input as to what they would like to see. And that's really helpful when our surveys will be practicing questions, because PCPs don't have the time to be sitting around for an hour completing a survey for some random graduate students. So by making it really condensed and shortening it down to 5 minutes, we're maximizing the number of people that would actually do the survey. And even though it doesn't maximize our understanding, it gives us a benchmark for what's the main places we should focus in, and then we can use those to do structure.
Okay. Yeah.
You're protecting your time by having the minimalist questions. Yes, and as an option. If you give them a space for you may tell us other things. There may be many who won't, but you might get people who say, I wish I could have told you this, and then they just type it.
So we thought about that, but we thought that by putting too many boxes of please explain, please.
No, just at the end, like.
I know. So at the end of the survey, we've included not our emails, it's the emails of Princess Margaret for confidentiality. And so if you've got any further impact, please feel free to reach out. We're happy to invite you to an interview or hear any additional comments you have.
So they may just dish, like the ones you do,
Right.
if they want to engage more, you create the space for them then.
Right.
Yeah.
Okay. Let's try this.
Hi everyone, we're here to provide you with an update on our capstone project, which focuses on investigating the adherence to quality indicators of pediatric emergency care.
Our team consists of Miranda Chan, Rafida Hawk, Mansi Maheshwaran, and Keshna Ravindran, who are the student PIs. Adita Marcon and Gilbert Sharp are the advisors, and we have Dr. Gabrielle Fryer, who is our mentor.
To start, the need that we're trying to address is the need for high adherence to pediatric trauma care practice recommendations. It is important to address this need as these recommendations were created to reduce variation in trauma care, which was shown to increase the burden of disease in previous studies. Adherence to these recommendations would ultimately lead to more effective and efficient pediatric care. Our goal is to assess the unmet needs that are contributing to the low adherence to trauma care recommendations, which, as we previously mentioned, is the overall unmet need.
Since our previous presentation, we have created a rough project plan and have sent that to our mentor, Dr. Fryer, to receive feedback and approval. The current plan is to conduct a mixed methods study. The first phase includes a survey provided to healthcare professionals. Then in the second phase, we would conduct semi-structured interviews with a few of the respondents. The goal of this project is to understand from their perspective what is serving as an obstacle to following the recommendations.
As we are waiting on approval, we're also developing a list of PAC members who we believe would be strong contributors. We have started reaching out to a few of them in order to gauge whether we would be compatible in a team. We're currently having conversations with them, but have not asked them to be part of our team just yet. One of the potential PAC members is someone we met during our contextual inquiries phase. She is a child life specialist who works at Sick Kids, so she would have relevant knowledge and experience. We're also reaching out to staff at Mount Sinai Hospital to get their perspective of general trauma care workers.
Moving forward, we will finalize a list of 5 to 6 potential PAC members and send it to Dita and Gilbert for approval. Once approved, we hope to officially form the PAC team and conduct our first meeting.
Okay, questions, comments? So when we think about these presentations, like compare it, maybe not compare it, doesn't mean that's necessarily the best, but look at the clarity. Okay, look at the clarity of the presentation. Do you understand what the project is about? Do you know what the need is? Okay, Gilbert, do you understand? Because you're just talking to me some of the projects that you don't really understand what the need is. So from this presentation.
Yeah, I think this is ours, so we've.
Yeah,
had discussions
we've had
about this first.
discussions about this, right? So, so questions? Yes.
What is a mentor in this, like, what is that going on?
Is that a PAC member or is it? It's because this project was introduced by her because it's like she is the one who kind of found those indicators that we were talking about and the middle adherence to it. But because she's directly involved in the project, she can't be a PAC member, like, collaborate. Yeah. So she's kind of like, she's also TRT alumni, so she kind of knows how PACs work, so she can like. I've given now that it's just voiceover, so I thought our faces and.
Oh, no, it's fine. Okay, so when I talk about clarity and conciseness, that's why I wanted you to comment on these presentations. Now, when I ask for comments on other people's presentations, I don't want you to be extremely protective of other people's feeling. I want you to be nice and I want constructive feedback. So don't say this is crap, but say, well, this could be better. Because you're gonna need that kind of feedback, right? So that's the thing. Like, it's better to get this feedback from your peers and in the class and from us, like Joseph and I and Gilbert, rather than go to your committee members or you're presenting to somebody outside and they don't like it, right? Or they have questions that you haven't answered. Because, when that happens, even at the PAC committee members, sometimes about a project, I feel like I blame ourselves because we haven't done the job to actually, talk about it extensively, right? So please give comments in the chat, otherwise, or to each other. Okay.
Hi everyone, Maddie and I are here today to discuss the update on our project, which focuses on understanding and improving patient experience in ketamine-assisted psychotherapy, or CAP, for individuals that have treatment-resistant depression. There is 2 parts to our project. The first part involves investigating and mapping out the experiences and the pathways that the patients go through as they move through the different stages of CAP before, during, and throughout the treatment process. And the second part focuses on identifying actionable strategies based on these findings and to recommend improvements that are going to improve patient experience and make it more positive and impactful. For the first part of our project, we're going to conduct a qualitative study using semi-structured interviews with patients who have either undergone, are currently undergoing, or have been referred to CAP. These interviews are going to be 45 minutes long, approximately, conducted over Zoom, and they will give us insights into patients' perspectives on CAP, particularly around any facilitators, barriers, or improvement opportunities. To help us organize the insights, we're going to create patient journey maps, or a single one, that is going to visually represent the pathway that the patients go through, along with several different factors that are important in terms of their treatment experience. And in the second part of the project, we're going to host a 2-hour expert workshop, bringing together 4 to 6 professionals in the ketamine field. And we're going to provide the professionals with our patient journey maps and our overall findings. And we're going to essentially guide the discussions that they have around gaps that the patients have experienced and how to address said gaps, and provide actionable strategies that are going to improve patient experience.
Okay, so as a progress update since our last meeting, we completed our REB application successfully, which we're really happy about. So that was like a big milestone for us that we were able to hit before the end of October, which allowed us to keep working on forming our PAC team. So far, out of the 3 that we ultimately want to have, we have 2 secured. So we have Dr. Adam Blackman, who is a psychiatrist and the founder of Metascience, and he works on a microdosing for psilocybin trial, and he also has a lot of experience working in ketamine-assisted therapy. And then the second member of our team is Kathy LaRock, who is a registered psychotherapist, and she works in ketamine-assisted therapy, so she's a great person with a lot of patient experience. Additionally, we've met with other stakeholders who won't necessarily be on our PAC team, but will also help give feedback going forward. So Rohit is the Chief Innovation Officer at iPath, which is a ketamine-assisted therapy clinic. And then also we signed up for the 3-minute thesis orientation session because we're looking to get into more pitch competitions and funding opportunities. Next steps, while we're waiting for our REB approval to come through, hopefully, we will be looking more into journey mapping frameworks to help determine which is the best approach for us. We're also going to continue to engage with our stakeholders and look into formulating a ketamine clinic database. Connecting with stakeholders will allow us to get a more comprehensive list of all the clinics in our area that we can connect with for patient recruitment, and also to ultimately connect the staff of those clinics.
Thank you for listening.
Challenges? What's the main challenge that you have experienced?
You're still to find our 3rd PAC member. Let's specifically somebody with the SGS, that's the nation like the somewhat of a hard time, I would say like that.
A question. What is patient experience? I guess, not what does it mean, but what does it entail? What are the parameters?
Patient experience is like anything that impacts how the patients perceive the quality of the care they're receiving, but it's not actually about the care stuff. Because we can't improve, like, we're not looking to talk about their care outcomes, like, we're not looking at treatments, it's their experience, like, personally. Sorry, I was here for this. You want to
So like our interview guide, it has very generalized questions about first, how did you access it, how was your experience in terms of accessing it? For example, did you were you offered like are they going to be offered this as a treatment, or are they gonna have to go and look for it? Like something that offers it, and then it goes to like, did you get preparation for your treatment? How did it, like very specific questions related to ketamine assistance.
Was it? Okay, makes sense. I get it. Like.
Yeah, the big thing is gonna be expectations. What do people expect from that therapy, and and that's gonna impact their satisfaction.
So one of the things that I was wondering about was, were there kind of eligibility criteria where, well, what did they have to have gone through to be deemed treatment resistant? Did they have to be on medications? Did they have to be washed out on medications? Were they given a chance to choose between, well, this is one dose regimen versus another dose regimen? Or maybe all places have the exact same practices, and like, are they given access to know that as far as choice? These were some of the things I was wondering about.
Well, the eligibility criteria for our study is pretty broad because, for example, it's for people that have been diagnosed with treatment-resistant depression and they have either undergone or are currently doing the PAP or have even been referred to it, because that's a recommendation from our PAP members that try to include those groups, because it tells you what is the barriers to access and what is the problem, why do they not want to take it, whatever. But in terms of the eligibility for treatment-resistant depression, that is not really.
So let's say at one clinic, they might say you have to have been on, an SSRI for at least a year and had this many, I don't know the qualifier, a suicide attempt. And that's their benchmark of resistance. And someone else says, well, the standard DSM-5 definition of resistance, that's a different eligibility experience. And when you look at the data, you might analyze generally, but if you ask questions about like, what was your eligibility, like what was required for you to get in, you might have subgroups that have different experiences based on different clinical protocol.
Yeah, so the DSM-5, the resistant depression criteria, is what we're basing ours off of, because like we want to include people from a bunch of different clinics. So if the clinics have different criteria, that doesn't impact ours, because we want to get it so much across. So yeah, I think as long as they have the diagnosis, we're just gonna. Okay, because I understand what you're saying, but I feel like for our study, like, we don't want to limit that.
So retrospective interpretation of your data, you might have different strata of like, oh, we included these clinics. These 3 clinics were extra expectations or requirements, and those people had a very different experience versus these other clinics we included that had a very different.
In our, we do have like a opening survey when we're doing our recruitment that they say what clinic they went to, so we'll be able to sort all of our quality data based on like parameters, so like all that stuff.
Okay, so that's the clarity issue. So you guys, so some of these questions, and I've said this before and I keep saying it, okay? Some of the questions that come up is not necessarily because you haven't thought about the project in a certain way, but you haven't explained it, or you haven't been clear communicating it, right? And so that's gonna be the issues that come up. This is why it's good to catch those.
Good evening, everyone. My name is Rachel, and joining me from our partner organization's office, PASAN, is Tala. We are here from the Healing Hope Coalition, a community-driven organization dedicated to advancing equitable healthcare access. Today, we're focusing on an important issue: improving the HIV literacy of Black women experiencing incarceration. So on tonight's update, we're going to remind you of where we had left off, as well as update you on our progress with our partner and what we're going to be looking at doing to move our project forward.
We'd like to start our presentation off with a quote by Dr. Maya Angelou. She made this quote during the HIV/AIDS epidemic in the 1980s and 90s. Do your best until you know better, and when you know better, do better. Through the course of this presentation, you will see pictures and descriptions of Black women who lived or are living with HIV and AIDS, who are trailblazers in developing institutions and programs for Black women living with HIV and AIDS across the globe.
So just to remind you of where we had left off, we introduced our pivot into the awareness and access of HIV/AIDS healthcare services, as well as began our partnership with Pasan and a presentation of our potential capstone timeline.
Here's a reminder of the stats that we shared in our last presentation. About 44% of newly reported HIV and AIDS cases are accounted by Black women in Ontario in 2020, and about 67% of newly reported HIV cases are accounted by Black female prisoners in the US. And the reality is that there are a lot of barriers facing Black women at trying to access HIV and AIDS resources, including stigma, fear, lack of information. And studies have also shown that physicians are ill-equipped and ill-trained to provide culturally competent HIV healthcare resources and services.
So our progress to date, we've identified an additional organization and partner, and through the IA Circle of Care for Black women living with HIV/AIDS, as well as conducted a successful environmental scan of in-prison programs focused on HIV awareness. So we've continued to engage with Pasan, and we've also attended community focus group sessions with parents whose children are experiencing incarceration.
How are we moving this project forward? Well, first, we'll be preparing for our meeting with Anton this upcoming next week. We're also drafting invitations to potential PAC members through the conversations that we've had in the summer and throughout the semester. We're adjusting our research question as we narrow our scope, and then revising our capstone proposal to be reflective of that.
These are some additional sources we've used to pertain the information to you guys, and just thanks so much for joining us tonight. We look forward to updating you further.
All right, challenges.
So I think right now, what's happened so far is that we've been able to identify the gaps. Where we had that meeting with Anton was today, so we were able to identify and verify the gap that there is a need for culturally centered HIV materials in terms of PrEP use. And we're still doing the whole PAC members invitation as well. I think our biggest challenge right now is trying to narrow down our research question and kind of smooth it over, because I think we've got a lot of information today, and so I think we need to go through that to kind of see where we want to funnel that down to. And Rachel and Hira, if you have anything else to add, please.
So the working research question that we kind of have right now is, can we develop materials surrounding PrEP that are culturally sensitive but also accessible and understandable for Black women, so that it's something that is targeted and relatable for them. That was something that Anton and us, we kind of discussed a little bit today with the use of materials that they have right now. They're saying that there's a lot more of a need for more information-based resources, but he had mentioned that for Black women specifically, there hasn't really been anything created in the way of materials that they can just simply take and share amongst themselves and use as tools to not only educate themselves, but also others as well. Just because with all of the stigma and everything that comes with accessing these resources and simply even going to a workshop or a program to learn more about it, there's a lot of barriers that they face and a lot of worry about whether or not they'll be quote unquote outed, or having it go on the record and having it reflect negatively upon them, that type of things. That type of thing. So having materials is a lot more comfortable for them.
Anybody else?
I just thought I was gonna raise my hand online. I'm still not full, so I understand the pivot, but I'm still not fully clear on what the current state is. Like, are people in prison with HIV, specifically Black women, not receiving treatment? Is that what's happening?
It's not necessarily that they're not receiving treatment, but what we learned today is that there is, specifically with accessing PrEP, there's a lot of hesitancy to ask for it, because it's usually part of the process is they would either be saying something along the lines of they're actively engaging in sexual activity, or they're actively engaging in drug use within the institution. So that does go on their record. And then obviously that will be something that could be up for additional charges, causing them to be inside the institution for a longer period of time.
So, but we talked about it previously, and I think Cheyenne mentioned that drug or injection or whatever using syringes, that PrEP does not necessarily is as efficient when the HIV transmission is through the syringe versus sexual activity. And I'm not really understanding how, like, I mean, sure, there's drug use in prison. I'm not sure how there's sexual activity in prison. And is the transmission from women to women the same thing, like, like that's one thing. So, okay. So my point is that overall, I think you really have to, you are probably at the same position that you guys are, Mikhail and Asya. In terms of the fact that you've talked to a lot of people, you have a lot of information. And I think now is the time to kind of synthesize that information and figure it out what's the population, because I do think that in your case, you really have to figure it out what you're focusing in. Yes, HIV in Black women in prison, and there is maybe no, maybe not adequate treatment, or maybe one of the things that you can say is that patient outcomes are worse in Black women than they are in white women in prison or in Black women in prison versus general population, etc. But what population is it? And again, I think it's the same question that somebody asked the other time, maybe it was me that asked, are these women the ones that already knew they had HIV and they ended up in prison? Or are they actually being diagnosed in prison with HIV and they are not diagnosed? That's actually a different population and different needs, probably. I'm not sure looking at PrEP is the right way to go, just because they're institutionalized, right? So is PrEP really effective even if they have access to it? I'm not, yeah.
Could try looking into like mitigating the spread of HIV in persons in specifically Black women population, if that is a problem that you identified, just any ways of mitigating it rather than just PrEP.
And yeah, and then mitigating spread is also something interesting, because I'm not sure if the prison actually has statistics in terms of if it's a problem, right? Because it's bad on them when if there is an HIV spread. And so they might not actually give you access to those statistics even if they do have it. Okay. And so again, saying it's a very hard population to work with, because not only they are marginalized, not only because of their their skin color, but also because of having the HIV and the stigma, and also by being in prison. So there's like 3 different things there that you're gonna have to be very, very careful on. But I think the main point for you is to kind of sit down and figure it out. Okay, what are we focusing in on? What is the actual project? I mean, because right now the scope is huge. Is this the new one?
What if instead of either, or perinatal before and HIV, how about open it to trying and figuring out what is the biggest problem for Black women?
Well, what about general access to healthcare in
Yeah.
prison for Black women versus other populations? Anybody online?
Sorry, what was the question?
What about looking at general access to healthcare for Black women in prison rather than specifying women with HIV or before perinatal care? Because that would also, right?
Can't get the.
You can't?
It's a closed shop. They're not gonna admit this.
Um, Yeah, I guess we could reach back out to Anton and ask them some follow-up questions. When we had kind of left the question a little bit open-ended. So when we were first asking him about HIV and like how Black women are accessing PrEP, and they kind of said, in addition to what we had already kind of reiterated, they didn't really touch on a lot about healthcare just generally, but they did say that, the staffing is fairly minimal. There's not a ton of clinical staff, and also with regards to like infectious diseases, there's usually one nurse on staff. So one nurse could be responsible for maybe like 400 people or so, however many people are inside the institution, and then there's usually like 1 to 2 doctors. So that could also be
This is
something, I guess.
So yeah, so this is something that we've talked about before. This is the problem when we talked about in the summer in a way. The trouble is there is no healthcare in prison, or there is no good healthcare in prison, right? And so the problem is general. And then when you say that Black women have poor access to health, or worse access to health than other groups, then that is good, and that is kind of a good problem to research, because that would also, so in a way, that would also, if you address that, that would also address problems of women with HIV in prison, because if they have better access to health, then they will also have access for HIV in a way. The trouble is, I don't know if you've heard Gilbert's comment, what he was just saying now, is that the trouble is they not gonna tell, Gilbert says that you're not gonna get the data that Black women have worse health outcomes in prison than other populations, because they don't want to admit that. So I'm not sure, like because you really have, you can't just say Black women have worse outcomes. You have to have data that shows that, right? And Gilbert says you're not gonna get that data. Even though everybody says it, nobody's gonna show you that that's actually the case. So you will never, so technically you can't really improve it because there was no starting point.
Might be able to see if any audits have been done, external audits on healthcare in prisons that might disclose something. Like sometimes the provincial auditor for provincial jails will do a thorough analysis.
Did you hear that?
I think he's too far away. I heard something audit, something.
Yeah. So Gilbert
Well, we meet with the group.
yes, you're gonna meet with Gilbert anyway, but he basically says that you might be able to see if there were any audits that were done or asked about any audit. So we're gonna move on, but that's a good question, and you can talk to Gilbert specifically about that.
Okay, thanks, Gilbert.
Okay.
Hello, fellow TRP students and professors. I am here to give you an update about our capstone project, Data Day, a self-management tool for individuals with early onset dementia and mild cognitive impairment. I am partnered with Lash, Kristen, and Hafsa for our capstone. So to recap, our project is in collaboration with Dr. Arlene Estelle and Erica Dove. Data Day was co-created with individuals with dementia and MCI, as well as their caregivers, and we are working to understand whether Data Day is an effective tool for these individuals. So since our last rapid update, we've met with our supervisors, Joseph and Gilbert, to refine our project's focus. Through these discussions, we recognize the need to clearly define our problem, need, and research statement, and together we've narrowed our scope and refined these core components. We've also connected with our collaborator, Erica Dove, and identified that we need to take a community-based approach to evaluate quality of life before and after using Data Day in these individuals. This approach will incorporate self-reported measures along with caregiver input. With this in mind, we'll continue refining our definition of quality of life to align with our project goals. Now, with these statements in place, we're advancing our literature review to deepen our understanding of the current state and help strengthen our REB submission for November. Finally, with the majority of our REB application initially drafted, we're actively revising it to reflect our refined scope and objectives.
So, taking a closer look at our updated statements, we've established that the problem is individuals with mild to moderate dementia and MCI lack tools for self-management. Therefore, there is a need to implement an evidence-based tool that supports self-management. Thereby, our research question asked if Data Day is an effective tool to self-manage mild to moderate dementia and MCI. So as we move forward, we'll continue reaching out to key stakeholders in the aging population sector to establish a well-rounded PAC committee. We're also making updates to our REB application to align with our refined statements and incorporate literature that supports the project's validity with the goal of submitting by the November 22nd deadline. At the same time, we'll keep progressing on our rapid review to deepen our understanding of the current state. And finally, we will maintain our commitment to weekly meetings with our team, advisors, and collaborators to ensure alignment and steady progress. For our PAC, so far we are looking at Dr. Christina Kokorilius, who has previously worked with our collaborators on Data Day, and potentially Dr. Alan Tam, an educator, researcher, and doctor at UHN. Also, Tyler Redupolo, a previous student of TRP with experience in age tech and health innovation. Thank you, and let us know if you have any comments, questions, or concerns.
Challenges?
So with regards to Tyler, we're not like 100% sure if he can, I know he's a therapist, but he's also like very relevant.
No, you can.
He can, okay. And we did have a bit of a challenge kind of navigating the collaborator relationship, but at our last meeting, we clarified it and they were very receptive to what we said, and we framed it as we're basically using their app as a case study to investigate our problem and research question. And so like, because originally they were expecting Dr. Estelle to be on the RE as a PI, and we would have to go through UHN, and we were potentially going to partner with memory clinics. So there would just be a lot of ethical and privacy issues, but we have reframed and like expressed ourselves to them, and they've agreed. So we are doing everything on our own terms, like as a community project with you.
So, you know that your PAC committee members have to be approved by your TFS, yes.
We still have to have meetings with all of them to like actually pitch our.
So don't do that until they get approved.
Oh, okay. So
because you don't want to ask them and then get them approved. What are you gonna do? You're gonna tell them you can't be on my committee right now? Like, you can't do that, right? So talk to them about your project without asking them about being on the committee. Then approve them, yeah, and then whatever, yeah. Yeah,
We want to talk about the project and just get like their.
yeah, but don't,
I just had a question, sorry, I don't remember from last time, so what is exactly the app? What does it do? So it's like a daily self-management app where people with dementia or their caregivers can track there's 4 different things. It's their symptoms related to cognition, nutrition, mood, and physical. So they have to log it in. Yeah, so they log it in themselves, and it's kind of like so the way it was designed was for patients to use, but like based on our conceptual input, we don't know how like how much they will actually do that. So that's why we wanted to involve caregivers.
no, we did that.
But I have a question. So the app is already made. You guys, your study is about like looking at the patients using it. It actually works or no? So the app is made. They like developed it. They tested feasibility to like see if the app works. But also, I think the way they tested feasibility is a bit different than what we are looking at. So basically, they want to implement it now, and they're stuck. So we're trying to figure out, like, is this even something that people with dementia want? So that's how we're looking. It's not necessarily we're going to implement this app. It's more like there needs to be self-management tools. Does this work?
Last one.
This is more like suggestion if you want some help in like understanding how to frame it. So Dr. Stella knows that there's a group in the Netherlands working with technology for people living with dementia. And some of their PhD projects are focused on if people with dementia won't use an app, what alternatives can they use? And like when you break it down, it's kind of looking at, well, if they don't like, if they never grow up with apps, then they won't be naturally like in tune to use it. And so they have some tools where it's like rethinking how you should program it. And so I don't think your problem will be, will people use the app? But it'll be like, do they understand that the app will help them? Yeah. And so it'll be more of like, how are they being supported by that? Yeah.
So the interesting part is that when you submitted your RIB assignment, your draft RIB, your introduction was really, really good. One of the best introductions that I've read, and the like problem statement and stuff. And the presentation is kind of clearly not that clear.
So the thing is, we did the REB first, the one that you read, and we got our advisors that we were.
Oh, okay, that's
So we
okay.
had to like audit it, so that's why I put it.
Yeah, but you have to think about it because the scope is important, right?
Yeah.
Okay, we're gonna move on just because time, but
Hi everyone, my name is Federico Carini. I'm a second year TRP student, originally from Argentina. I'm also a critical care physician working here in Argentina. And this presentation is on my project for my capstone on a primer on analgesia, sedation, and delirium in the ICU. Being admitted to the ICU is stressful both for patients and families. Patients require mechanical support, including ventilation, drugs, lines, monitor, etc. And they're gonna need some kind of sedation and analgesia. And there is usually a lack of awareness from the team on how to better manage these important topics. Through the years, we have developed a very big body of knowledge on these topics, including the bundle A to F and the ICU Liberation campaign. This bundle that we just mentioned is not being adequately implemented at this stage. There are many studies looking at barriers on why this is not being implemented, and amongst many others, one of the barriers is the lack of knowledge in the critical care team about these strategies. That is why I propose this TRP project, which basically includes discussing a new curriculum for the training of ICU physicians in topics related to analgesia, sedation, and delirium. And this will be informed by the involved stakeholders. This is key. We're going to do focus groups, trying to understand what people need. And by people, I mean everyone included in the professional ICU team and patients and former patients and their relatives. We're going to be producing a hybrid course with this information, which is going to be both online and the script for the in-person workshops. And then we're going to produce, of course, the capstone for the TRP. This is what we have already completed. We have already convened the PAC committee and we have the first meeting. We are through the process of the RIB presentation in Canada. We already completed that in Argentina. We are starting to convene the focus groups, at least the candidates, because we need RIB approval before we can actually do the focus groups and then the analysis. Then we're going to do the curriculum design and assembly the online platform. We're going to be doing the pilot testing, hopefully by March, April 2025, and then doing the analysis of results and the manuscript preparation and the final capstone presentation. Thank you for your time. I look forward to your ideas or suggestions.
challenges, Federico?
Right now it's drafting the RIB proposal because I need to follow the regulations from one hospital in particular, and then also prepare for U of T. But I'm working with my supervisor there at Sinai, so hopefully I will get that done before my next PAC meeting in December.
Questions?
I have one. I'm going to put out there. I don't know if you have it already, but the security team in the hospitals are the ones who are called in when there has to be restraint. So I'm guessing that sometimes when someone's in a state of delirium, they may lose regulation. And I actually met a hospital, like, security guard, and he was explaining how the nurses and doctors call him in. Families may need to know to expect it, maybe that reduces some of the strain, and the physicians understanding what helps those people do what they need to do could be informative. There may be things that those people wish your clinicians were taught. I don't know if that's in your scope or not, but I thought I would raise the concept.
Okay, let's move on. We have.
Hi, welcome to my project, Improving Meaningful Incorporation of Patient Partners' Contributions in the Collaborative Initiatives. My name is Dominique Pilon, and I am supervised by Edita Marco. I present to you my pack, which is consisted of 4 experts to provide guidance in my project. And as you can see, I'm still looking for a patient partner expert. I also have the pleasure to work as a mentee to Danielle Rolf, who is gracefully volunteering her time to help me in my methodology. Patient partners, or PPs, play a vital role in healthcare improvement, providing perspectives that enhance quality, ensure relevance, and support patient-centered care. Despite their importance, there remains a gap in effectively incorporating patient partners' contributions between healthcare organizations, healthcare professionals, and patient partners. While the presence of patient partners is recognized in various levels, healthcare professionals often lack the skills to fully utilize their insights. A common concern among them is the absence of formal education on effectively integrating patient partners' insights, which may hinder collaborative initiatives. My research question is as follows. How can healthcare organizations effectively integrate meaningful patient partners' contributions in healthcare collaboration initiatives? To best answer my questions, I will need 3 points of contact with 7 healthcare professionals and 8 patient partners, as seen on this slide. A PAC member recently recommended me a framework on evaluating engagement capacity led by Julia Abelson from McMaster University and published last year. This framework evaluates 6 core competencies needed for fostering engagement, 4 domains of supportive infrastructures and enablers, and an assessment to gauge an organization's position on a maturity scale. This provides a roadmap for identifying priorities to advance up the maturity scale and enhance patient partner engagement and collaboration. Several concepts from this framework could apply to my project, where I'll assess my organization's capacity to engage with patient partners, and I believe exploring these correlations will be highly valuable. My project is on track. I have submitted my REBs to both local committees and the University of Toronto. I aim to hold my PAC meeting by the end of November, pending a formal engagement of a patient partner expert. To deepen my understanding of the field, I am currently speaking with several patient partner experts across various settings and countries. And amendments will most likely be required, and I have already begun refining my approach with the guidance from my experts. I do have a question, on the other hand, is there any tips on making professional and creative engaging presentations? And I'm looking to learn more on the logistics of creativity and presentations, and possibly explore options that do not have cartoons. Thank you.
So Dominique, I think you know who to reach out to for creative presentations here.
Yes, I saw. I noticed.
Challenges that you have experienced?
My challenges were in line with being able to connect with patient partners for a potential PAC membership, and also one of my major challenges is the local REB is extremely very rigorous, so it's a great learning experience at the moment. And I just recently received some information to adjust my local REB. And what happened since last time? Well, those conditions I need to fill. I have 17 conditions I need to adjust on my protocol to be able to pass the local REB. And I also solidified earlier this afternoon my final PAC member. So I aim to host my first PAC meeting by the end of the month.
Good. Any questions? This is the last one to go. So any questions? Okay, so this is the last one.
Hi everyone, my name is Daniel, and on behalf of my group partner Carl, I'm here to present the updates for our project. So again, we are focusing on functional neurological disorder. This is a disorder which manifests as tremors, numbness, fatigue, seizures, and even gait changes. This is the second most common diagnosis for outpatients in neurology clinics. Unfortunately, there's no biomarkers or neuroimaging methods for diagnosis. All of this can compound together and create a delayed time for diagnosis, the average being 6 to 8 years before an individual can receive a diagnosis. Now, specifically within the family of different FND diagnosis, we have FCD. This is a very important subgroup, and it stands for functional cognitive disorder. Currently, there is no treatment pathway for patients who are diagnosed with FCD here in Ontario. And our project looks to provide a novel solution that can hopefully be installed as a long-term solution and treatment pathway. So our project, we're looking to collaborate with the Toronto Rehabilitation Institute, Sunnybrook, Toronto General, and Baycrest. With their neurologists, they will send us referrals of patients who are diagnosed with FCD. With that patient group, we will then split them up further into two subgroups. We have first the individuals that will receive the traditional treatment, and then we have the group of patients that will be enrolled in our psychoeducation intervention. This will be an online group therapy session designed by Carl and I. It will be a 7-week program. Participants will be enrolled, and we will receive their feedback both from the patients and the care providers who are involved in this entire system, starting from the doctors who are giving the diagnosis from TRI, Sunnybrook, Toronto General, and Baycrest. Our hope is to collect this data from all of these individuals in the project to help support future FCD pathways, grant initiatives, and both inpatient and outpatient clinics. Currently, we're working hard on putting together our REB and have that submitted and approved so that we can start the project and the actual study in the winter of 2025. We're also working on a large grant proposal with the aforementioned stakeholders, where our project will be used as a pilot study to help support their long-term initiative to create more infrastructure for FCD care here in Ontario and Canada as a whole. Carl and I are also in the progress of making the actual program and having that ready to go for January of 2025. And of course, this is a continual thing, but just stakeholder management. We have a lot of really big and key pieces. Fortunately, we're connected with every top neurologist or therapist or anybody really who is seeing patients who are diagnosed with FND or FCD. So it's just a really interesting task, just having to manage all of those stakeholders. Thank you so much, and we look forward to giving more updates in the near future.
So I'm not sure, stop share.
I put my questions in the chat for one.
So this was the last one, so I don't know if either Carl or Dania is there. The one thing that I have concerns kind of is the scope. If it's a 7-week program, how are you actually going to evaluate? First you have to recruit people to it and whatever. Okay.
What is the study? That looks like a trial. Trial?
Well, no, the study is preparing the, in a way, preparing the presumably. You can't, they are going to do it, but presumably they're going to do it with the input from the neurologist and prepare some kind of psychosocial therapy session for 7 weeks. And then just evaluate before and after, which you can do it, right? But I'm not sure if that's possible. Okay, So we can discuss that with them when they're here. Now, one thing that I wanted to mention, first of all, on Zoom, I can see even later on who was actually on Zoom and for how long. And if you had your camera on or off, okay? Now, the next class when we have, there's gonna be no computers. Nobody's going to be on Zoom except one computer so that people that are actually online or are not here can see it. When people are presenting, I should not see anyone typing anything in the computer unless it's later and you're putting it in the chat, okay? So there's no distraction. I know it's easy to get distracted. I get very easily distracted online. I mentioned it previously, which is why, you know, in person at least I keep track of what's happening. But yes, so my point is for the second time, again, I also see, by the way, how many people and who opens the SharePoint file with all the presentations, okay, and each presentation, okay. So it's not like I don't know if there's 5 views, I know that you haven't seen it, which is basically why this is not an elementary school, by the way, okay? Seriously, you doing it for yourselves, okay? You want to see what other people are doing because you want to see, you know, how you doing and compare it, right? So I can also see who does what, okay? So next time when we have these rapid updates, I really need you to look it up and have comment so we can actually have a more of a discussion because there's going to be more issues that come up, you know. Now we are all starting. So the main issues are really, you know, scope, identifying the need, identifying the problem, identifying the research question, and maybe how to structure it. Later on, we're going to have issues with recruitment. We're going to have issues with RB revisions. We're going to have issues with data analysis, you know, how and how. So these are the things that we want to discuss, okay? Not actually spend all the time like presenting. So please look at the stuff beforehand, okay? And like I said, next on